Now, mental health care is a part of the culture of how we provide cancer care. But we did not get there overnight. Some of the digital technologies, as well as some of the therapeutic bots that have been designed specifically for therapy, are making a difference in people's lives and are decreasing their depression, their anxiety.
When we think about AI innovation in mental health, AI should really be used as a signal amplifier, something to sharpen the clinical senses of the astute humanistic clinician.
Welcome to AI in Healthcare. My name is Dr. Sanjay Juneja. I'm a hematologist and medical oncologist, also known as the OncDoc on social and news media. And I'm joined by my co-host, Dr. Douglas Flora, the editor-in-chief of AI and Precision Oncology. And today, Doug, we have two of your friends to discuss something very important that can't be discussed enough, but also can't be figured out, and that's mental health.
Yeah, I'm excited for this one, and we'll get into introductions here in a bit. But just to set the table for the team, look at what we do. So Sanjay and I are both medical oncologists, and our job is sort of the mechanical part. So imagine you're taking your car to the mechanic because it keeps crashing. We fix the bumper, we align the tires, we polish the hood, but we never ask if the driver's asleep at the wheel. And to me, that's oncology without psychosocial care. We fix the biological engine, but we ignore the human distress during the outcome. And so we have a couple of guests tonight who are really good at figuring out that second part, whereas you and I need the help.
Yeah, and if you haven't heard about things like Therabot or how AI is able to kind of pick up with natural language processing and even appreciation of the tone of voice, where, depression or some emotional distress may be, then this is an episode that I think really relates to anybody that's dealing with any kind of illness that's stressful, both for patients and the ones, that love them, as well as the one that are providing the care. So with that said, Douglas, why don't you go ahead and introduce us to our two guests today?
Sure. Well, these are old friends, especially Kyle is very old. He's my oldest friend, so I'm excited to have him on here. This is Dr. Kyle Bonesteel. He is a longstanding neuropsych expert, trained through Northwestern, Loyola, and has been in practice for some time himself as a thought leader and what I would say is the tech side of the brain. And we're going to get into some details about what that means and just how precise can precision mental health become. Kyle's also CEO of a company called Neurostratus that we're going to get into and has really done some remarkable work with some large language models trying to make diagnoses more objective rather than the DSM-5 of older years. And then we have Jennifer Byers, who is dynamic in her own right and has been leading the charge at Inova Healthcare now as their executive director over just about everything that's supportive care, social work, psychosocial navigation, and the rest of it. She's also sort of an international superstar on the talking circuit for AOSW, AONN, ACCC's board. And if there are things happening around mental health innovation, it's usually Jen. So welcome to both of you. Jen, how are things going out in D.C.?
It is icy here, but, there was a little sunshine out today. Things are going well.
And Kyle, you are in the balmier climates of Chicago?
Oh, yeah, it's warmed up here lately, so that's good. It's about 7 degrees now, so it's feeling pretty comfortable.
Well, I'm super excited to have both of y'all. And because we only have one episode, at least I'm sure this is going to butt off into more, but I'm going to get right into it. Kyle, I'm going to ask you first, just to frame us kind of on what, passion really drives you to spend what it sounds like very long days and years on tackling certain challenges when it comes to mental health and addressing it. If you could fix one choke point in mental health today, like overnight, what would that choke point be?
Yeah, it's a great question. And again, thank you for having us on this, I think, very, very important discussion. But I think, Sanjay, to answer that question, I would say the number one choke point is the lack of diagnostic clarity at the front end that we often deal with in mental health. What I think we need, and what is in development as you see the progression of precision mental health information, is that we need automated, comprehensive, objective diagnostics even before we start treatment that then can allow us to precisely prescribe therapeutics that not only match the patient's diagnosis, but the underlying mechanisms that are giving rise to that diagnosis. And so if we can do that at scale, at the same time that we're also minimizing clinician burden, I think we would have taken a very important step in the direction of scalable mental health. Right now, what happens is we meet with the patient, there's a verbal narrative, we ask some questions, and then we get a subjective snapshot. And that's often not good enough for the high stakes decisions that needs to happen subsequent to the initial assessment. And so it's also prone to bias. Patients decide to tell us certain things, but not others. And so the more objective we can get with our diagnostics at the front end, I think the better that everything else can unfold therapeutically, because it really always comes down to efficient outcomes.
I cannot wait to tease that further, but I can't give Jennifer too much time to be able to prep, even though I let her be second. So Jennifer, please, what is one thing that if you could snap your fingers, you'd love to fix?
I think top of list is access. When I really think about mental health care in this country and really anywhere, access is really an issue. Getting the right patient to the right type of mental health care at the right time is something that we really have not figured out, from having enough trained therapists to really getting that patient to that right type of therapy. So I think access to the right type of care is super important.
So guys, obviously in oncology, we're dealing with some existential dread. We're dealing with all sorts of deep sadness, of grief, of loss of hope. And it's murky, right? I think for us, we're used to having an objective biomarker. We're used to having this is an EGFR exon 19 positive lung cancer. And then we come to you guys and you're still working from a field guide, right? It's a 1952 manual, this DSM-5. I think, are we on 5 now? It was 4 when I was a student. It shows how much progress we've come in the last 30 years. And I know it bugs both of you that we don't attack these with more precision. Kyle, can you talk a little bit about the clinic that you work in now and how you are approaching this a little bit more innovatively? You and I have talked a lot about functional EEG, functional MRI, and what you're doing with brain mapping. Can you talk about what you are gleaning from these newer versions of tests that might guide better therapeutic and treatment decisions?
Yeah, absolutely. So if we take a step back and we ask ourselves, if you go to an oncologist or you go to a cardiologist, what's the likelihood that they're going to evaluate the physiology of the organ of interest? The answer, they always will. Okay. So in mental health, we all intuitively know what the organ of interest is. It's not our elbow. It's not our knee. We know it's the central nervous system. We know it's the brain. Okay. But hardware analysis like MRIs and CAT scans don't help us all that much. So that's really where the advent of functional imaging comes into play. And we utilize a lot of quantitative EEG, which is able to non-invasively measure brain activity at different frequencies, brain waves, circuitry patterns, and so on. And then we can compare that to the norm for an asymptomatic patient and then cross-correlate that with their clinical history, their neuropsychological test data. Why is that important? Because so many patients come to us and they kind of know what's going on. They kind of know if they're depressed. They kind of know if they're anxious. They kind of know if they have cognitive issues. So it's not enough for us to arrive at a diagnostic label. We need to go down to the level of granularity, etiology, understand the mechanisms by which that symptom recurs over and over again. And that necessitates us looking at brain circuitry. And so I've got to tell you, it's deepened my understanding the last 25 years of what people go through. It's not uncommon for me to look at a brain map, look at neuropsych test data, and just have a deep wave of empathy, because the brain dynamics, when they're dysregulated, really trap that patient into a symptom circle that they sometimes feel it's very difficult to get out of.
Sanjay, can I sit with that for a beat? Just think about that in our specialty, or even take it a little bit broader. Go to a cardiologist and say if they just treated chest pain the same way for everybody, right? Some have heartburn, some have a clogged artery, some have a panic attack. You give them all aspirin, only 30% of them are going to benefit. And I feel like that's exactly what we do with SSRIs right now. With our antidepressants, we throw serotonin at everyone when some people might need dopamine or glutamate or something else altogether. And I love when Kyle was starting to teach me this, and this is why I wanted to have them on here to talk about, can we nudge mental health into that newer era to give these guys more targets and more tools to make more carefully launched decisions?
Yeah, I just hope that's clear to the audience. Is Kyle, you're not suggesting that at first somebody might hear it and say, oh, so you need objective measurements and metrics to qualify or classify someone as depressed or having mental distress. That's not what you're saying at all. You're saying there are flavors and types of this emotional distress or depression, and characterizing them helps the next step of serving anyone who might have, the ailment of these kind of problems, but in a more precise manner, rather than perhaps a more crude categorization that doesn't give you that next layer of objectivity or assistance, the same way that we treated cancer just by what they were on a slide, histopathology, and you didn't have now the sequencing or the RNA and the DNA, and that's really kind of uncovered that not all lung cancer is the same. There's small cell, non-small cell, and then, different kind of biomarkers, et cetera. I think that's just so important. On a similar note, Jennifer, I was wondering, how do you see, when it comes to accessibility, what has changed in the last 10 to 20 years, other than the fact that we know that a lot of people need it, a growing number of people need it from everything I'm reading. And I can only assume that there hasn't been a, let's say, proportional increase in the ability to be able to, satisfy and address this. And then on top of that, I'm sure there's additional things that go into helping these patients than before. So you actually need more time, and you don't have a proportional amount of scale to be able to meet them.
I mean, the awesome thing that has changed is we're having this conversation. When I entered oncology some years ago, we were barely talking about mental health. We were not screening patients for distress. We didn't consider it part of care. And I think that's not only true in oncology, but we're really seeing it everywhere. Some of it is in TikTok and people accessing types of care through ChatGPT, which I think has its limitations, but I think the big change is that people are recognizing that mental health care is important and people are demanding care for it. Now, on top of that, we've developed some screening tools, but they oftentimes screen for a point in time. Or we're asking a patient to subjectively remember, in the last 2 weeks, have you experienced something like this? And so while it's great that we're screening people more, they are not precision screeners. And there are important things to take into mind. One, what the screening tool tells us, but also what's going on in a patient's life. What are their living situation, their relationships? And all of that needs to be layered on top of some of this precision medicine that Kyle's talking about in regards to someone's mental health and accessing mental health care. And being able to get a full picture of someone without having to have them fill out a screening tool every time they come into the office is really important. And there are novel ways that we are finding that we can do that don't impact a person's day-to-day life, but give us a heads up way earlier than we've known originally that someone may be struggling and may need some help.
I feel that way in our center, Jen. We have traditional distress screening, but I've always felt like it's like a smoke detector with no batteries. We say, are you distressed, on a clipboard once a year or maybe 3 times a year? And if they say yes, the alarm goes off, but there's no fire truck coming. We don't have the staff. We don't have the tools. It's almost cool to ask if you can't act. For you guys at Inova, you built a wonderful program, one I think that others can try to emulate. How did it go there to get the support that you needed? I guess to convince people that treating the tumor without treating the terror is an incomplete prescription.
I mean, I think we've been really lucky at Inova that a grateful patient over 30 years ago gave a donation, or it was a patient's partner that gave a donation to start the program. And slowly by slowly, Inova was paying attention to the impact that was making in patients' life in a way that now mental health care is a part of the culture of how we provide cancer care. But we did not get there overnight. It has taken over 35 years, little by little, to build what is really an incredible program. But a lot of centers don't have access to that type of program. And even though we have the program that we have, we are still missing patients, or we are connecting patients with the wrong treatment at the wrong time, or there's so many options and we are expecting them amidst a cancer diagnosis to figure out, do they need something for brain fog, insomnia, anxiety? And so while we have this incredible program, we are still really lacking in how we match patients in a way that's really meaningful and effective right from the start.
So when I listen to both of y'all, I get so excited. One, because Jennifer, you're talking about the things that are, conventionally how we think about both identifying and providing help to individuals that have mental health issues that obviously has truth to it. Like there's obviously something that works, so to speak, with the identification. And then Kyle, you're talking about, splitting or partitioning that out further. Now, I think the key here is if any traditionalists or conventionalists, when it comes to the characterization or listening, there's nobody saying by any means that we're forfeiting those. It takes, kind of both of them together. And I'm only saying that because it sounds like anything you say with AI is all of a sudden like, well, is it going to replace XYZ? And I've read going into this podcast on Bioengineer, one of the publications in their health section that talked about these kind of sophisticated algorithms and machine learning models that enable systems to identify these subtle patterns that are indicative of mental health distress, almost imperceptible to human clinicians when it comes to even vocal analysis when you're listening to the virtual counselors that they're engaging with, and then also with wearable devices. Like for some reason, my Oura Ring just was like, "You've been stressed out all day, bro," and I was like, really didn't feel like that stressed, but it showed me objectively where it saw the heart rate variation. So my point in saying all that is, we're not saying like, oh, which one's better. We're saying, and what I'm hearing is, one can be potentially earlier, and second, they can help kind of define and stratify these to a higher degree. But I think there's a place for all of it. We used to kind of identify cancer when we saw it or felt it, like on a physical exam. It's still there. It still helps even with response stuff. But in an ideal world, you catch it before it's palpable, because that has to be to a very large size. And it sounds like we're going to kind of be up against, Kyle, tell me how this could be the case, of treating stuff before they get really magnified and kind of phenotypically, obvious to the naked eye, so to speak.
Sure. Well, objective measurement is a data-driven process. And what scores and metrics aren't ever a problem unless they're invalid, inaccurate, or misused and overinterpreted as the end-all be-all. So, when we think about AI innovation in mental health, AI should really be used as a signal amplifier, okay? Something to sharpen the clinical senses of the astute humanistic clinician. And, there's some analogies here in medicine. When a surgeon goes into surgery, we would hope that they have preoperative imaging. Okay, we want them to know what they're dealing with before they get in, and then have some kind of dynamic monitoring along the way to inform them whether they need to change or have a course correct. Well, in mental health, we need to know before we're treating. We also need to have some kind of mental health fluoroscopy equivalent, if you will, okay? And that's where longitudinal tracking comes into play, that allows us to really correct what we're doing when it's not working, have some kind of iterative feedback loop that allows us, through successive approximations, to get to a therapeutic strategy that actually moves the dial for the patient. So, human clinicians will never be replaced. But really what we need to point the clinician to things that perhaps they weren't privy to, things that they did not detect in their clinical interaction. And that really positions them to do more of what they are brilliantly skilled at doing, which is being humanistic and bringing together sort of the rest of the therapeutic package.
People fear that introducing an app or an algorithm into mental health will dilute the human connection. I think in our conversations, we think it could be just the opposite. Is this the technology almost like a hearing aid that lets us detect that quiet suffering that we've been missing for decades? And you've taught me a lot over the last couple of years as we've gone through this, but think about things like, if we look at a patient who's stopped filling their prescriptions 3 weeks ago, and I can hear that silence and understand that there's disaster coming, or how monotone a depressed voice will get on a cell phone. Or I think we all understand that when you're depressed, there's some psychomotor retardation, even in typing. Can your phone be a proxy for I'm well? And then when you're not as well and you're typing slower, maybe there's a heads up and more of a hearing aid. And so you've taught me a lot about the prospects, not just in the counseling stuff, but in the power of the data, recognizing these really subtle patterns that would elude the human eye.
Yeah. I think there's a real tangible human payoff when we start to integrate AI in mental health. And I'll give you an example. Again, I come back to the practice of medicine, and we have to remember that the practice of mental health is different than the practice of medicine. The practice of medicine is organ-based, physiological-based. Mental health is psychology, consciousness, conscious processing, habits, brain waves, circuits, neurotransmitters. So when we think about how we can help the mental health sector, when we can provide insights back to the patient about themselves, just like your medical doctor does, okay? They don't ask you why you have heart disease and what your ejection fraction is. They tell you, right? Because they're figuring that out. So when we can, in the mental health sector, provide patients insights about themselves, what does that do? Well, first of all, it creates a lot of confidence, okay? And, we know we're not going to cure this mental health condition overnight. So we need buy-in. So when you go to someone, you go to a mental health system, and it's informing you about you in ways that you think, wow, that is so spot on, your confidence goes up as a patient. You feel like you're in the right place, and you start to have more buy-in, which is what we're going to need therapeutically from a patient if we're in fact going to get where we need to get therapeutically. The second piece of it, and Sanjay, you said this so beautifully, we need to understand the psych types and the biotypes. I'll give you an example. When a patient comes in and has depression, what does that mean, right? Well, it could mean that their left frontal region is significantly underactive and is affecting their social desire and reduces their ability to feel joy. Or it could be that the circuit down the midline is significantly overactive and they're ruminating and really stuck in a self-deprecatory loop. Could be trauma-based. We need to understand those components, be able to say that back to the patient so that they understand that we have a deeper understanding of them. And now we can move in the direction of therapeutic matching. I might say the second piece of that is, what do we do in between sessions? I once had a patient say to me, Doc, that was a great office visit, but what am I going to do the next 167? I said, the next 167? He's like, the next 167 hours until I come back for my next session. And I thought, wow, this gentleman is leaving my office and he's got to figure out how to manage all that he's managing and white knuckling it until 167 hours later when we resume where we left off. And Doug, I think that really speaks to, and I'm sure we'll talk more about this as we go through today, how we can use digital therapeutics and digital phenotyping to keep track of what's going on with patients so that we have ways of intervening even when we're not face-to-face. So for all those reasons, you can just think about the possibilities of how we could have more coherence in our mental health systems.
The precision is what gets me so excited. Maybe I'll send this Jen's way. So we need better sorting, I think. We don't have objective measures for any of these things right now. But if you have 100 depressed patients, Precision Health would tell us that 20 may need intense psychiatry and meds. It's a clear biologic issue, whereas 50 might need cognitive therapy because it's a psychological issue, but 30 just need a care navigator to fix their financial stress because it's a social issue. And I guess where I'm hopeful is I've seen this happen. We're maybe 10 years ahead in oncology, where we've finally gotten away from just having lumps to now very, very specific sub genres of tumors. And I see progress being made when I talk to you guys, and I see you both give talks around the country, that you have tools available to you and to your brethren now that I couldn't even have imagined a while back. So, Jen, I saw you speak at a meeting a couple months ago, and you were talking about some of the data. Maybe to keep us honest here and not just so optimistic, can you talk to us a little bit about what the science is telling us here about this? Is this just signal, or is this just noise?
If I was a good researcher, I would say it's probably too soon to tell. We are seeing great promise in some of the studies that have been done to show that some of the digital technologies, as well as some of the therapeutic bots that have been designed specifically for therapy, are making a difference in people's lives and are decreasing their depression, their anxiety, or other pieces that they're coming in with, like insomnia. There's a great app for CBT for insomnia, which is a fairly manualized intervention And so delivering some of these more manualized intervention with less people and more adherence to the actual intervention that's been studied has been shown to do really well. And some of these approaches have been more personalized in these studies too. I think what we want to be mindful of is there still needs to be a human in the loop. There still needs to be someone who's overseeing the treatment. There still needs to be someone who's connecting with the patient on that human to human level, but that there's so much that can happen between sessions as an aid to the therapist in the session that really is showing great promise in the literature. And so it's not something that we want to say, no, we're scared of, let's not look at it. It's something we want to say, let's learn more. We need to dig into the signal a little bit. Do we need to make a tweak here or change something here? Because there is real promise in what we're seeing.
Combining your two answers makes me kind of actually relate what you're saying really in between the visits, and how like there's so much counseling had and so many, pearls delivered, that ultimately a patient is just on their own responsible to try and incorporate and practice and perform. And today I was building this autonomous workflow, an agent that basically, for meetings, everyone can talk about what they want to discuss. And then it really leverages the power of large language, these frontier large language models, because they are so good at understanding what happened, not just by the words objectively, but by the principle. Is there anything that you all have seen or can think of where you could actually leverage large language models to also give feedback between the visits, right? So like, say somebody says, hey, try not to perseverate so much, or get, you're getting anxiety about these decisions and going and not having the confidence of going forward with your decision making. There's no doubt that a large language model will be able to understand when you have successfully kind of accomplished that thing that you discussed in these visits. And I saw at Health these wearables that apparently already have data showing that dietary preferences get modified on their own based on the color of how hot the glucose spike is after certain meals. And they noticed that people started actually like modifying even the sequence of what they're eating. I have to imagine that kind of feedback would also be very favorable and kind of reinforcing for those 167 hours, Kyle, that you mentioned. Are we leveraging or considering leveraging large language models in the outside clinic outpatient setting?
I think that the potential is endless there. And I think the challenge, though, Sanjay, is who needs what? So the LLMs can do an amazing job, I think, once we steer the diagnostic picture in the direction of the LLM. Let me explain. So if we've got a good front-end analysis of psychopathology, the psychodynamics of the patient, the personality profile, if we've got that clinically, which we can do at scale, that's what we do in neuropsych all the time. If we've got that at the front end, now that can steer the LLM, it can steer the digital therapeutics in the general direction of where it needs to go. And an example would be if there's borderline characteristics, borderline personality features in the personality constellation. Okay, that's fantastic to know, because now we can steer the AI in the direction of that. And already the AI, even though it doesn't know the person, it's got the requisite diagnostic information that's then going to create a very, very useful digital therapeutic that can help them with their exact psychodynamics and the things that they struggle with. So I think that's where there's some really exciting potential there with taking traditional neuropsych assessment and all those tools and leading it down the path of how do we set up the LLMs to then do what they do so fluidly and wonderfully. So I think there's a lot of potential there.
I've also seen some companies that are using ambient listening in the therapy session. And then in between the sessions, patients are journaling or marking their mood. And based on what they're entering into the journal and the mood recognition, it's refeeding some of what they learned in the therapeutic session and some of the behavior change or coping tools to help the patient start to integrate those. When I heard you talk about the color of glucose monitoring, you're talking about behavioral change. Behavioral change is hard. We are creatures of habit. And even if it's a good change, we don't want to do it. And so thinking about how we can better kind of give someone a nudge, a little tap on the shoulder and say, hey, you wanted to get better at this, or pay attention to how you feel after this happens, really starts to integrate that and give the therapy much more power, because it's not only working 1 hour a week, it's really integrated into a person's life.
I love some of the tools that are coming out now. Sanjay, you and I are starting to see these on our side as well with wearables and those sorts of things on the oncology side, and talking about starting to do hospitals at home and infusions of chemotherapies at home, because we can be smarter about monitoring.
I'm curious, in cancer, science itself, let alone AI, has taught us that we are perhaps or definitely doing things incorrectly. So, we used to recommend things in medicine. There's all these things you can, ask a LLM, like, hey, what are mistakes in medicine that were just totally wrong? And we learn later, that it matters. Or even something that wasn't completely wrong, but there's this data at ASCO that talked about the timing of immune therapy for a bunch of theoretical reasons that make sense, may, influence perhaps, response rates. What do you all think about, or are there even discussions about how AI might disclose that we are perhaps doing things incorrectly? So not that we can't even deliver, but how perfect or imperfect is the possibility, and I'm saying this truly naively, about all of these very good, CBT and all of these different kind of things that we have come up with that have shown data. Do you think that we'd actually learn, like, oh, actually, this is missing the mark a little bit, and it seems like we should be saying this instead, et cetera?
Oh, sure. There's so much that we don't know in the mental health space. I think pattern recognition can only serve to provide us with some incredible insight and knowledge into what is working and for who. I mean, I think like Kyle started us off, we are kind of throwing things at people and hoping that they work, whereas we are not getting the right thing to the right person when they need it most. I think there's so much learning that can happen that will certainly shape how we're providing care moving forward. And one of it with access will be keeping people healthy and focusing on well-being rather than waiting until someone is in a situation where their mental health is so bad that they need deep intervention. But I think that there's so much to learn about how the brain works and how people receive different interventions. Mental health care has not done a great job on focusing on outcomes. And so I think this gives us a real opportunity not only to match the right patient with the right type of treatment, but also to look at the outcomes in a different way.
I wonder too, Kyle, I don't know if you've seen anything about how we could potentially obtain objective measurements of things that act like surrogates to perhaps some of the brainwave patterns that you're seeing on an otherwise large lift to have to get into a machine and get it scheduled and all of this stuff. Possible like teeth, jaw clenching and mastication tension. I wonder how many things we could potentially validate as a surrogate for patterns seen at different moments of somebody's journey with a mental health illness, because, otherwise half the visit is spent just recounting everything that happened between. And so we're obsessed with this remote patient monitoring concept and everything, because for the same reason, you're basically trying to discuss and how unfair it is of us to kind of ask somebody to chronicle all of this, over 167 hours. I'm just a little obsessed with this kind of idea of, by far the majority of the time that exists outside of the room, to really give us clarity on, potential explanations of why we're seeing improved patterns and other things that we may not appreciate is solely responsible because of an SSRI or because of a certain strategy when it comes to intervention.
Yeah. So it's imperfect right now, but there are a number of psychophysiological metrics that are fairly easy to collect that can give us information. So heart rate variability is one. We know that heart rate variability is altered and dysregulated in states of sympathetic fight or flight overdrive, anxiety states, sleep onset insomnia, some forms of ADHD, and in depression. So that is a very easy metric to monitor from a cell phone with really simple monitoring devices that can be used at home. The other piece that you had mentioned about the brain mapping in point of fact, that's one of the wonderful things about quantitative EEG is that it can be done with a headset. We're not talking about going into an fMRI or PET scanner. There's no injectables. This is simply, a device that, and they're coming out, and we'll also be developing our own, whereby this can be just placed on the head, non-invasively, collect the data that we need, and start to track circuitry improvement or change as a result of biological methods. So, and then we've got all the digital phenotyping, the voice inflection, affective linguistic type of technology that is monitoring changes in voice characteristics and how that pertains to changes in psychological state. So I do think we're moving in the direction of fairly easy to use mobile technologies that can be used for what I think is the holy grail, which is the development of digital twinning. And when that patient comes back for their next visit after the 167 hours of white knuckling it, not only can we ask, how have you been since I saw you last, but we can also say, let's look at your psychophysiological systems here and let's learn what it's telling us, not as a replacement for human therapy, but to really hone in on where that therapy needs to go. So I think the future is bright because things are becoming more mobile and really easy to use. A lot of that, Sanjay and Doug and Jen, is really kind of a newer version of the biofeedback that has been around since the 60s, 70s, and 80s, and now we've got mobile capability, which really allows it to be implementable in a fairly easy to use sense.
So, a couple of medical oncologists are going to love early detection, right? It makes a ton of sense in our world. It makes a ton of sense in your world. And for the naysayers out there that are, still holding on to the idea that it has to be either or, I'm not suggesting things like digital strokes or the psychomotor retardation I was talking about replace the empathy and the other stuff. But it's not dystopian to me to prevent suicides. For me, some of this early warning signs, these early things, hey, listen, this patient usually has this level of activity. They've not left their couch in 9 days. Those sorts of things can be very, very important signals that are harbingers of doom that you guys can act on. I guess for Jen in the clinic, for you, what do we do if we start to get better at diagnosing these conditions? Because there's still no one to take care of them, right? We're still really, really short in mental health professionals, and we're not making enough of them for the number of people who would benefit from having them. So can you see a role for tools like these digital tools being extenders to give you the ability to take care of more patients per day, per week, per month, in places that are remote or rural or Black or brown or impoverished that don't have access to you or Kyle?
I definitely think some of these digital tools can be extenders. I also think if we get better at diagnosing what people need, we can better titrate what we're giving them. And so maybe instead of using a trained clinician for every single person who has high distress, for some people, depending on what that distress is, they get a digital intervention. For some people, they get a medication. For some people, they get a medication and therapy because that is what we know they need based on the information and data that we gathered. So I think it's not only extending what people can have access to, but we're really getting the trained clinician in the right place at the right quantity.
Yep, I love that. It's precision mental health isn't just about finding new drugs, about making sure we don't send a surgeon to do a social worker's job, and we don't expect a social worker to walk into a room to fix a neurochemical imbalance. So precision.
And, in addition to probably just the diagnostic part and hitting it with what someone needs, it's also, potentially going to disillusion some of the things that they may not need. Because I have a habit of saying that AI is going to really help us deconfound. I really should probably look up to see if that's a word. But there's so many confounders of, that contribute to things. We know the human body is a complicated process. So like poor sleep, hygiene and other reasons for what's called dysphoria or, a mood that's thrown off when it comes to hormone regulation and, my residents would say, Dr. Janeja, you're obsessed with sleep apnea. And I'm like, because sleep apnea causes so many things. So every person I see with a high, blood count for hematology, I'm doing a deep screen. Or someone I see that's on testosterone replacement, I'm doing a deep sleep study screen. So I think the cool thing would be this kind of multivariate, multimodal analysis that also just helps us say what it is and what it isn't. Because it's not just with AI, but just technology in general, that when you could actually start considering and plugging in these different modal components, modalities of the full body assessment, because we know how intimately physiology with neurochemical, with mood, all of that is put together, that when these foundation models come out and can consider all of these different things, I think it's just going to make it so much more, hopefully, likely to just hit it on target, where otherwise you may just not know because something's outside of your disease, specialty, or out of your element, or something requires, additional lab testing. I think that's where the guidance will be really huge, to concentrate people to be able to do what they do best.
There are two things that come to mind subsequent to what Jennifer so eloquently described. One is, if you go to 100 cardiologists, what's the likelihood that there'll be some unanimity, some consistency of how things are conceptualized? I think the answer would be there would be a lot of consistency across those 100 cardiologists or oncologists or whoever. If you go to 100 mental health specialists, I can guarantee you the heterogeneity of the paradigms, how clinicians conceptualize what is going on, will be markedly varied. Just the other day, I was talking with a psychologist in the immediate area, and I wanted to refer some patients. And so I asked her, how do you, what do you do, and how do you do it? And she described to me that they do longer-term psychodynamic, psychoanalytic therapy. They focus a lot on early traumas and the effects of family of origin. I thought, well, that's great. But I thought to myself, wow, how different is that versus what I'm doing in clinic? It's not to say that one's better than the other, but it really exemplifies for me just the amount of variability in mental health paradigms. That's not a bad thing. In fact, it's a phenomenal thing if we can fit who needs what to the right paradigm. That's really the goal, and that's really I think the challenge. But if we can solve that, we have plenty of effective therapies. I mean, that's not the issue. But we've all had that experience. So you prescribe that medicine and the person comes back and they're like, oh my God, thank you so much. Yeah, the same pill to the next person. They're like, yeah, not impressed. All right. Well, why? Right. And so I think that we have an inherent challenge in mental health because of the tremendous diversity of paradigms, but that can also be used to our advantage if we can do it right.
And I think when people don't get better quickly, they quit or they don't come back. And by being able to really tailor the types of interventions we're offering people to their unique needs means that we're going to be more successful. People are going to get better quickly. And then we can better utilize those resources to help somebody else.
Kyle, you're an interesting neuropsych in that you also have prescribing privileges. You did a couple years of extra servitude and went back for additional training. How has that experience doing that a little bit later informed your treatment selections? Because I think, Sanjay, we probably, I don't want to speak for you, buddy, but if somebody needed sleep, I'd give them something at night, that had some sleepy side effects. If they were anxious, it used to be Paxil, then it became, Celexa or something else. And now I think it's almost all Lexapro. How does someone who actually understands how the brain works and the pharmacogenomics work, who's seen these functional MRI, choose an SSRI or not?
Yeah. It's been a very interesting journey because pharmacogenomics can be very, very useful. But as we all know, it is not. It's not the answer key, and it tells us a lot about how the patient's going to metabolize the medicines. It can give us some leanings as to what pharmacological regimen would be a best fit. But again, it's not the answer key. So what I've really tried to do is to take pharmacogenomics, circuitry analysis, and neuropsych data to then synergistically inform me. That's been an interesting journey because I do believe it gives me the more precision in terms of the rationale and the logic for what I'm prescribing. I'll give you an example. A common pattern in depression would be this area called the left inferior frontal gyrus, and it's overactive. Okay. Well, if it's overactive, you don't want to give it Wellbutrin. Wellbutrin's a little too activating. Okay. Psychologically, that person is going to be more likely to be prone to feeling guilt for things that aren't their fault. Okay. So with a situation like that, I'm going to lean to a less activating SSRI, maybe a Zoloft with the dosing possibilities that are very incremental. The therapy is probably going to be a little bit more geared toward internalized guilt and some of those feeder systems into depression and dysphoric mood. And then we're going to come around and think about some neuromodulation to quiet that area down too. So it's a long-winded answer, but it's really designed to try and fit the psychopharmacology to what you're actually prescribing to, which is not the diagnostic label. It is circuitry. I mean, when the day is done, it is a neuronal intervention. It has psychological benefit, certainly, and can have it, but you're prescribing to neurons. And the better we can figure that out, I think the more precision we can have. And it's a work in progress. I think any of us in the field, we've succeeded a lot, but we've also failed. And you remember those times when you've come up short for people, and you just don't want that to happen the next time around.
Well, what I love about what Kyle's saying is that there's a way to take out some of the subjectivity of mental health care. And there is so much stigma attached to asking for help or admitting that you're struggling mentally. Because I think as a society, we have oftentimes thought of it as a shortfalling. Someone's either not working hard enough or not trying hard enough. And what Kyle is talking about is we can objectively look at data and see what's happening and see how one brain is working differently than another and how that's impacting their ability to be in this world and to be in life. And when we think about stigma and think about people not being able to access mental health care, and of course there's many reasons for that, but some of that may be a belief system or how we think about mental health. Having data like Kyle is talking about is so powerful for patients and families to start to begin to understand why they may be having the experiences that they're having.
If I can ask you all in closing one question, I would love to know, what is it about either large language models or AI or technology today or in the last couple of years that you find most exciting and hopeful when it comes to addressing this, really pandemic issue when it comes to mental health? And what I'm reading is worsening. For me, I'll tell you, I read somewhere that there was a surprisingly large percentage of conversations directed at these frontier LLM models for advice and also just kind of discussing something out loud about the way one might feel. And my hope is that in doing that, if we can see something precipitate that would direct one to be more vocal about possible underlying mental health diagnoses or illness issues, etc., then that's going to be a big door opener for many. And that's my hope, because I know a large percentage is just not even sharing, and also potentially physicians not knowing to ask. So with that, what is one thing that excites you all about how something will potentially really change when it comes to AI and technology and mental health?
Thinking specifically in oncology, I am really excited that we may not have to rely on the patient or the physician to tell us that someone needs help. That there is an automatic process by which we know someone needs help and we deploy it. I think, there's nothing worse than hearing, I wish I would have known about this sooner, or why didn't anyone tell me that this service existed? It really breaks my heart when I know that these services exist. And so if we can take out the human and the identifying, because we're all really busy and the stress can show up differently for people in different ways, and we can just quickly know who needs help and get them the right help, gosh, that would be super exciting.
I think what I'm so excited about is the the possibility that mental health as a treatment paradigm can mirror what's going on in oncology. So in oncology, obviously, you all don't wait till it's stage 4 to treat it, right? But in mental health, that's kind of what we end up inadvertently doing. It's when the proverbial stuff hits the fan and it's kind of mental health stage 4. Now, we bring the fire trucks, we bring the fire chief, right? Well, there's an issue with that, because the longer a person has a mental health struggle, the more recalcitrant it is, the more difficult it is to treat. So I think what I'm so excited about is the use of innovation and AI to start to understand when someone is converting from, metaphorically, stage 1 to stage 2 on that mental health continuum, be able to identify that, okay, and essentially have the equivalent of a good smoke alarm. And when a little grease fire, starts, you've got the therapeutic equivalent of a fire extinguisher. And if we can keep utilizing, therapeutic fire extinguishers to keep grease fires from progressing into engulfing the entire kitchen, I think we would have done something very, very important. We're not there yet, because we're usually seeing folks at sort of level 3 or 4, stage 3 or 4, and now we got really something more severe on our hands. So I'd love to see the whole system move from a reactive perspective to a proactive, and then ultimately to a preventative. And I've seen this in mental health in 25 years. It's amazing, the transformation. You hear it especially in the younger generation. They talk about their mental health freely. They look at it, I think, sometimes as an opportunity, fortunately, as an opportunity to feel better. It's incredible how it's changed in the last 25 years. So I think we're really primed to get people to look at it just like their physical health. Let me lean into things that are preventative, so that I don't progress through into stage 3 or 4 mental health crises. But we got to give them the tools at the front end and be able to identify what they need, when they need, much earlier at the preventative stage.
Sanjay, I'll tell you what I'm most excited about is there are people like Kyle and Jen out there doing this stuff, and you can tell they're good people. They're dedicated to making human suffering go down at scale. And I tease them a little bit because they're two of my dearest friends, but I love them dearly. And I'm so proud to be working along you guys' sides to make this a bigger deal. For all too long, and I think Jen and I have talked about this a lot in our lives at the Association of Cancer Care Centers, mental health has been kind of an afterthought, and it was never front of the line. It was never top of mind, forgive the pun there, but now through forums like this, with these tools arriving on our doorsteps, people are finding them anyway. One of the top uses right now for generative AI is dumping trauma and having a private conversation with somebody who might give you some insights into box breathing or managing your anxiety in your bedroom. And I think with the appropriate guardrails and training, that is an incredible step forward for people who had zero access to care before. And with people like Kyle and Jen at the wheel, I feel like we're probably going to get there 10 years faster because they're leading the charge, not just watching it happen. So thank you guys for coming aboard. This has been really instructive for Sanjay and I, because we don't live in this world. For me, it's all Lexapro all the time. I don't know any better, but after hearing Kyle talk about the things on the side of the head, I don't even know what that is. I'm going to have to read again.
I'm going to have to use AI to see what these two wonderful humans see in you, Doug, if they're close friends. Maybe one day it'll solve that one.
Yeah, that's a fair question.
Sanjay, I don't think AI is that advanced at this point to be able to really understand that part. That's in this.
There's something wrong with his medulla oblongata.
Well, if you like what you heard, we'll have more guests just like this. Please tell us in the comments what you'd like to hear in the future. And as always, we appreciate both your interest and your educational pursuits. Till next time.